today. For those of you who've joined us and not quite sure how it works, then our speakers will do a 30-minute presentation, during which time your mics will be off. You can, if you want, you can keep your cams on, or you can switch them off, up to you. After 30 minutes, then there'll be 50 minutes questions, excuse me, in which case, obviously, you can switch your cams on. And if you've got a question, put your hand up, either on your clicking the button or just holding your hand up. And then there's a 15-minute break for you to go and get a cup of coffee or something or whatever. And then we go on to the next presentation. And we've got 3 of those lined up for you.
Matt?
Yes.
And one more thing.
Mm-hmm.
Remember when we're talking with Natalia about the speed of speakers?
Oh, yes, true. Speakers know this already because they're pros. But even when you guys are asking your questions, just bear in mind that you have got Natalia in the background trying to keep up with you. She's a professional and she'll handle it. But if you can remember that and slow down, I'm saying that really fast, aren't I? If you can remember that and slow down slightly, basically speak more like Maro, then everything will come.
No, my English is so bad.
So the message is be Maro today, people. Be
hashtag.
It's okay. Hashtag be Maro. It's okay. Don't worry.
Don't worry.
Right, so I'm going to stop talking and leave you with the wonderful Trevor Prior. Take it away.
So can you hear me okay?
Mm-hmm.
Yeah, has the share screen come up?
Certainly has.
Okay, I've just broken into a cold sweat because I realise how quickly I talk and you've got a translator, so we may have to link up afterwards, so apologies. So we got half hour to discuss orthoses and footwear, which is a challenge. I could probably spend half a day, if not a day, on these. But thanks, Matt, for inviting me to come along. And here we go. So declarations. I'm a director of Run3D. Jess and Nick went through that with you yesterday. But I'm also on the facility and 𝐕𝐈𝐃𝐿 think tank and innovation lab, which involved with designing and manufacturing orthoses and footwear. A part of the brief was that runners may be logging in. So just to start with, in order to talk about footwear and orthoses, we need to be thinking about kinematics, which are essentially the angles and dangles. So when we look at people on a day-to-day basis, the positions we see that they're in, and it's really been the basis traditionally for footwear and orthoses. However, we're now starting to think a lot more about kinetics, which are the forces, the loads that are applied to the joints, the force across the joints. We often call those joint moments. So we can see a joint in a particular position, but unless we've got specific equipment, we can't really measure the forces going across those joints. As a historical perspective, the traditional approach was really outlined by Ruth, Orion and Weed back in the 60s. It was very structural, that there was this one perfect neutral position around which everybody should function, and that we could then design orthoses that would put people nearer to that position and resolve all evils. It didn't take long for us to realize that actually the foot was pronated through out stance, so we never actually achieved that neutral position. And furthermore, in a nice study by Cornwall and McPoyle, they looked at people walking and found that there were 4 patterns of pronation in a normal population, and therefore everybody pronated, but they pronated in different ways. More recently, Jarvis and their group looked at the traditional factors that we would assess for the Ruth, Weed and Orion basis, and that would be the forefoot to rear foot position, ankle dorsiflexion, first MTPJ dorsiflexion, and the neutral and relaxed stance position. So they measured these in a range of people and then looked at their dynamic function. Well, their results were fairly conclusive. These were not predictive of dynamic function. So if they couldn't predict walking, they're certainly not going to predict running. Back in the 80s, 𝐃𝐈𝐒 started talking rather about pronation and supination position, but more pronation and supination moments or forces. So that's the kinetics. And he described how these different forces may affect the loading on different structures and therefore symptoms, and how the subtalar joint, which is the joint that sits just beneath the ankle joint, where the axis of that joint sits, will also affect the loading, and that axis position changes from individual to individual. Should also note at this point that when you assess the rear foot and you're looking at the inversion and eversion as a quasi guide to the amount of pronation and supination, you're actually looking at the ankle and subtalar joints combined. You can't separate the two out. Dannenberg observed that the majority of motion occurred in the sagittal plane, In fact, the motion is far greater in the sagittal plane than the transverse and frontal planes combined. For that to happen, you needed first MTPJ dorsiflexion. So if you place your foot flat on the floor, lift your heel off the ground, you will feel that for every degree of ankle plantar flexion, you require a degree of first MTPJ dorsiflexion. So he discussed how if that motion was limited, the first MTPJ can't dorsiflex, then you have to have a get out of jail strategy. And effectively, you can't plantar flex your ankles, so you flex your knee early. And because you flex your knee early, you can't extend your hip. And therefore, you have poor auto support. And so we have a kind of different approach that we can take. Well, where does that leave us? Well, there are a couple of systematic reviews that looked at how foot posture may predict dynamic function and how that may be predictive of injury or injury prevention. And really, they found very little evidence to support any of those concepts. So whilst it's a nice kind of concept to consider, there's actually no scientific evidence for any basis of prevention or treatment. So 𝐒𝐻𝐞𝐫, observing this back in the 90s, he took a group of people and he provided them with a range of orthoses that were designed to reduce rear foot eversion and tibial rotation. And what he found was that the individual response to each orthosis was completely different. There was no structured kinematic response to each individual orthosis. And in fact, in some people, the eversion increased or the tibial rotation increased. So they actually achieved the opposite of what they aimed to do. In a nice study by Williams and their group, they did a similar study. And what they did was they took runners who had been treated with standard orthoses that didn't work, and they then provided them with an inverted orthosis. And an inverted orthosis is one that effectively has a much greater arch support and provides a greater force to the foot. They provided them the inverted orthosis and they were successful. So they also looked at eversion excursion, so the range of motion, and the degree of eversion, and found that there was no significant difference, and that again the responses were individual. However, in that study they also looked at the inversion moment, so the force applied to the medial aspect of the foot, and they did find a systematic response to the orthoses. So with the standard orthoses there was a 25% reduction in that moment, but that wasn't significant. However, in the inverted orthoses there was a 54% reduction. So their conclusion there was that the rear foot position doesn't change, but we can change the forces. However, what's often not reported when discussing that paper is that they did find kinematic responses, but they were more proximal to the foot. They happened further up the leg. Interestingly, they saw with the inverted orthoses that there was increased tibial rotation, and you might suspect it should be the opposite way, but also changes in knee adduction and abduction moment. So whilst we don't get that kinematic change at the foot, it happens elsewhere. So what about running shoes and injury and prescription? Well, we're aware now that the traditional prescription techniques for providing running shoes has no evidence, scientific support whatsoever. In fact, for injury risk, there's limited evidence, other than perhaps one paper that has shown that in a pronated foot type, there were, in a prospective study, subjects with a pronated foot had less injuries with a motion control shoe. But their definition of pronation was based on a static measure, the foot posture index. So we have to kind of, the evidence is there, but it's limited. So a bit like Boris, does that leave you a little bit confused? It ought to do. I mean, Runner's Need back in 2018 made a fairly good stab at describing the gait cycle, and even went as far to say that you should be just looking for the most comfortable shoe, which was probably a step change. But they then went on to talk about overpronation and underpronation, the injuries you can get and the preventions that you can do. And clearly we know now that there's no scientific support for that. I had a quick search around on the net, and it's not surprising people confused, because the running shoe companies are still using the same old terminology and groups. And if we look at some of the shops that are the running shoe shops, again, using the classic arch height, the wet footprint, loading patterns, etc. And we could tell now that these clearly aren't relevant. But I understand why they do it, because they've been given nothing to replace it with. So 𝐒𝐻𝐞𝐫 is one of the groups that have done some really interesting studies, and they looked at a group of runners and put them in shoes with either a viscous content or an elastic content, so varying the give of the shoe. And they demonstrated that the oxygen consumption and the muscle reaction to the different shoes varied between individuals. So again, not surprisingly, individual responses. But interestingly, the muscle responses happened just before a foot strike. So they talk about muscle tuning. In a nice review, 𝐒𝐲𝐞𝐵 suggests that if you look at all the papers on impact forces, there's nothing to suggest that these are responsible for injury, but more an input signal that then results in the muscle tuning that we see just before heel strike. So what he proposes is that this minimizes vibration and it reduces tendon and joint loading, so the kinetics. And whilst that may affect fatigue, comfort, work and performance, he suggests that trying to align with shoes and inserts which cause small and inconsistent changes should be rethought. So the muscle tuning is thought to maintain this kind of preferred movement pathway for the individual, and we were discussing that last night in the Q&A. And anything that kind of pushes you away from that requires increased muscular activity. In the same paper, he also looked at the comfort side of things, and where studies have looked at assessing shoe and insert conditions, different subjects will select different shoes or features. So some people might like a slightly higher heel height, or some might like some medial loading. But if you look at comfortable versus less comfortable shoes, the more comfortable shoes have less movement-related injury and less oxygen consumption. So he proposes that a comfort filter is perhaps a pretty good guide to how successful something is. And that kind of where things have sort of stayed with the old thought processes in this really interesting recent paper by Walton and their group. They asked physio students and shoe salespeople to self-rate what they thought about their education, their ability, their knowledge of shoes to control pronation and the effect shoes have on running-related injuries. And the number of physio students that felt they had a good knowledge in each was less than it was in the salespeople. So the salespeople self-rated that they had a better level of knowledge. Both groups actually had a relatively poor understanding of the relationship of training error to injury. Perhaps almost disturbingly, a shoe salesperson was much more likely to just recommend a more expensive shoe, and perhaps even further were prepared to change the shoe even when the runner was happy with the shoe they were currently running in. Now, I have to confess, back in the day, I used to do what everybody did. I'd send someone down to the running shoe store. I'd get 3 different shoes back. We'd take our traditional measures. We'd even use in-shoe pressure analysis. And I'd say to the runners, don't tell me which one's the most comfortable. I'll tell you which one I think functions the best. And 9.5 times out of 10, the one I felt was the best was the one that was most comfortable. So I basically stopped doing it and said, look, here's the type of shoe I want you to get. Go down a running shoe store, try on about 4 or 5 and work your way down to the most comfortable, and that will be the best. Matt, I'd kind of like you to do a little survey at some point and tell me, I want to know how many people listening were alive in 1992, because that's where this slide came from. Out of the depths, you can see the quality. And this is a runner where you can clearly see the left foot's more pronated than the right. We put them into the shoes, but the right shoe deforms more than the left. Why is that? Well, the way I perceive this is that there's a force being placed onto the foot. The right foot's less able to compensate for it than the left foot. Therefore, when you put something that's more mobile between the foot and the ground, i.e. the shoe deforms more, which takes us nicely onto this little picture that's been doing the rounds on social media of 𝐒𝐤𝐞𝐫. And we can clearly see now that's not going to be the foot position. That's the shoe deforming. And way back in the day, we were looking at some of the 400-meter runners and getting the video from the track, and we can see with this particular runner, although they get a 4-foot strike, the majority do get a heel strike, and we can see there's a degree of pronation there. You don't need the precision, but as he hits the bend, we can see the angle of attack is different, the loading is going to be different, and the foot goes into a completely different position. And I was actually asked to control that with an orthotic. Well, any orthotic that might be able to control that would be the wrong orthotic for the straight. So to give you a couple of examples, this is was a good level club runner, but kept getting right-sided injuries. If you can have a look at the Run 3D data that we got from this particular girl, we can see on the right side, so red's right, blue's left, there was a high angle of inversion, and the smart people will see that she's a 4-foot striker on the right and a rear foot striker on the left. So it'd be classic to be inverted at 4 foot. Both shoes, because we're measuring shoe deformation, deform the same. But because it started at a different position, the range of motion is greater on the right side, and interestingly, reduced tibial rotation. So what does that all mean? Well, if we freeze in mid-stance, if we'd had a classic approach to this, we could see this right shoe's more everted, and therefore she may have been put into a more stable shoe. But what happens when we look inside the shoe? Matt, can you just confirm for me that the video is playing, please? Matt? I'm hoping that video is playing, because if it is, yeah? What you'll see is she does not get any heel contact whatsoever. All right, so although the shoe looks like it's in contact with the ground, clearly if you stuck her into a shoe with more stability, that's not going to help. And her problem was basically she's got an excessive step length, so she contacts with the forefoot. As the heel lowers, it doesn't contact the ground, and she goes into hip abduction, and that's why she had reduced tuber rotation, because there was no heel contact. So she'd actually suffered from heel pain 7 years previously, and effectively had taught herself to run without contacting the heel on the ground, and she had no idea that was actually the case. And we know that there's a subjective feedback in terms of how you contact the ground is pretty poor. So there was an interesting discussion to be had with her about whether she really wanted to go for changing her running style completely, combined with a rehab program, and she did. And I'm pleased to say that because she went through the process and it enabled her to get to a point where she could train past the injuries she had, she subsequently went on to win a major marathon and run for GB. So head plant 1, I've had a gait analysis. So the patient comes in, you're going through and recommend the gait analysis, and they tell you you've had it because they've been down the running shoe store and had a form of gait analysis that's just looked at the running shoe, but doesn't really tell us what the foot's doing inside the shoe. Because this was geared a little bit for runners, I was just going to put some of my basic thoughts on footwear selection, really around experience, body weight, distance, speed. I think most of the things that we consider, whether we're talking about strength, movement, footwear, whatever, sit on a spectrum. And if we think about, I always try and get the lighter shoe on a patient. Clearly an elite experienced runner or someone with a lighter body weight may require less of a shoe, whereas a novice or someone with a higher body weight may require more of a shoe. And interestingly, with the novice, clearly if someone takes up running, their requirement when they start is likely to be different to their requirement perhaps 6 to 12 months later, when they become fitter, stronger, and more experienced. So they shouldn't be stuck in one thought process of shoe. If we then think about the distance and the speed, so shorter, faster runs are going to need less than longer, slower runs, and you might think about going into some kind of specific race shoe, if that includes a carbon fiber type shoe. And then, well, we talked yesterday in the question and answer where I kind of said, well, sometimes I use the shoe so that rather than saying you need this type of shoe, what do I want the shoe to do? And I kind of sometimes think about that with forefoot stripe, because that we're finding that the sagittal plane function is really key. I haven't got every type of shoe you can have here. We talked yesterday about how a barefoot shoe would push you towards the forefoot, but not necessarily. The first real barefoot shoe was the Nike Free, because Nike observed that the loading pattern in a traditional trainer was different to barefoot. So they came up with this unique last and designed a shoe that mimicked the pressure pattern that you would get, but provided some protection. And they actually did some research that showed that these shoes, as part of a training program, would increase the range of motion of the MTPJs and improve flexor strength. We have the Hokas, so we find that patients tend to have more of a midfoot strike in a Hoka. It pushes them more towards that, and actually on 3D dampens quite a bit. And this was the shoe we started off that runner. I explained that we wanted to bring her back to a midfoot strike. If I want someone to have a bit more of a heel height, then I'll push them towards a certain shoe. If I want to dampen vibration, I might consider the Salomon Predict. And I guess any discussion on footwear wouldn't be complete without discussing the 4% range. 𝐒𝐩𝐞𝐚𝐤 did the initial study where they compared this prototype shoe to traditional shoes, and they looked at compliance, how much the midsole gives, and resilience. And they found that the energy return that they got in their prototype shoe was far greater, 87%, although a lot of that was due to compliance. But when they looked at the oxygen consumption, the energy efficiency, it was 4%, hence the name. But where did that come from? So clearly the Pebax foam they use gives energy return. The carbon fiber plate, we know it reduces MTPJ action, and that's a negative power. So if you reduce the loss of negative power, then there's some effect there. 𝐒𝐸𝐿 talks about the teeter-totter effect, whereby it moves the plate moves the center of pressure distal to the ankle, and therefore there's a longer movement arm that effectively pushes the heel up, although that's been questioned in terms of physics. And there's the geometry of the shoe, and in reality, it's probably a combination of those, and as importantly, the runner that's wearing them. More recent studies have looked at the degree of stiffness and the energy cost, and what's becoming apparent is that the type of stiffness you require in a shoe depends on the speed at which you're running. But they're not without injury. This is a case of a runner preparing for the marathon, decided to wear her new 4% to do a half marathon. This is the pressure picture towards forefoot in a Adidas Boost. And in a Triumph, you can see why they're different. They're both towards the medial forefoot. We stick her in a 4% Vaporfly, and we can now see we've got much more lateral load for a longer period of time because of the plate. And what appears to have happened there is it caused increased perineal activity and therefore gave her symptoms. But this was a case of too much too soon. So she just went for a run for the first time and did 13 miles, which perhaps not sensible. This is a slightly busy slide, but this is another patient of ours who was pretty happy with their 4%. They're fairly symmetrical pelvic and hip function, ankle dorsiflexion, slightly low tibial rotation. We compare in the next percent, and now she goes asymmetrical at the pelvis and the hip and at the ankle, gets no tibial rotation. So two different reactions to two different shoes, and if we look at the structure of them, they're clearly different. The angles are different. The degree of rocker is different. So they're not the same shoe, and she responds differently. And her natural feedback that the 4% was more comfortable was borne out by the data. So if we consider everybody's bringing out a carbon fiber shoe now, and we think about how stiff is that plate that's in there, what's the degree of rocker, how much material and type of material is there above and below, what's the heel drop, they're all going to function differently. And therefore the likelihood is different runners will find a different one more comfortable and more efficient. So how do I now think about running shoe choice? I have to confess, since I've used the 3D, I've recommended far less stability shoes. In this particular instance, we can see the right shoe is deforming far more than the left, but it's also got reduced tibial rotation. I know from the studies we've done that if I give that patient a stability shoe, it will reduce the tibial rotation further, which is not a desire. Furthermore, in reality, she needs a different shoe for each foot, and that asymmetry is most probably due to the asymmetry in terms of knee and ankle function, and that should be our target rather than the shoe. So in terms of shoes and key points, I aim for as little shoe as possible. Size matters. Most people, 90% of people, in the wrong size shoes, so just changing their size usually helps. And then I decide on what I want the aim of the shoe to be. Then I tell them to go down to the running shoe store and find the most comfortable one, because I rarely need stability shoes, particularly if they have a good rehab program. So what about orthoses? How do they work? Simon Spooner described in a roundtable discussion how they alter the forces on the foot by their shape, the stiffness, and the friction. And the majority of the time we're looking at shape and stiffness. So that then takes us on to the arch and arch mobility. So the relative height of the arch is important. And if I show you this particularly fine specimen of the foot, which means it's mine, we can have a little look if it plays for me, which it doesn't want. There we go. Excuse me. As I pronate my foot, you can see that my arch moves to a certain extent. And if we take a flat foot and we're going to do some surgery on it, what we do is re-establish the medial column, the arch of the foot, to give it some stability and reduce motion, because that's the deforming force. Langley and his group looked at arch motion and footwear, and they looked at the three of the classic types of shoes. And what they found was that a motion control shoe will reduce the degree of eversion between the forefoot, midfoot, and the rear foot, but at the expense of the sagittal plane motion. So they could reduce the eversion, but that includes increased sagittal plane motion. They make a supposition or propose that the control in the rear foot of the shoe, and maybe the torsion of the shoe, has an effect on the eversion of the midfoot. So it's an indirect action, but you're still going to get the sagittal plane motion, which clearly you can't affect with the shape of the shoe. So that takes me to head plant 2. The patients tell me, no, I don't need anything there because my shoe's controlling the midfoot. Well, how can it? The inside of the shoe is flat. The only shoes that are perhaps different, if you look at, say, the A6 range, where the heel height of the shoe effectively gets extended more into the arch, so it drops off at a more distal point. If you have a lower arch profile, that can be uncomfortable. And this somewhat busy slide is trying to show us that we can have a pronated or more supinated foot type, but at one end we're going to have a stiffer foot type, at one end we're going to have a more mobile foot type, and similarly with the supinated foot. So an easy way you can take particular measures of navicular drop or midfoot, changing midfoot height. An easy way to do it is just get someone to stand on tiptoes and see how much the arch changes, and that gives you a pretty good idea about the range in which you can work. So if I have a stiffer, flatter foot, I'm going to use less of an arch profile. If I have a more mobile arch type, I might use a greater arch height. And similarly, if I'm, and that's because I'm in a pronated, if I've got a pronated condition, I want to apply supination moments, but I'm going to do that by changing the shape of the device. Similarly, in a more supinated foot, I want to be doing something more laterally if I've got lateral problems and tendons. Although in some of those patients, we just spread the love a little bit. We get just more general contact, so they have a better overall contact, so we spread the pressure. So I will use I use the Facility range because I'm familiar with them, that go from a low profile up to a high. And this is actually a tissue stress design device by Tom McPoyle, and devices specifically to increase pronation moments for that more supinated foot. So when we now look online and they tell us we've got the most common injuries and how to avoid them with these custom insoles, or the 5 best running insoles available, which basically have virtually no features in them other than a bit of cushioning. Clearly, and if we know that every individual responds to an insole in different ways, really, yeah, well, less said. So that takes me on to head plant 3. I've already tried my insoles. They haven't worked. Well, yeah, okay, fine. That doesn't mean they can't if they're designed in the right way. So if an individual's response to orthoses are variable and footwear is unpredictable, how can we assess proximal function? Because I've explained that orthoses can have kinematic effects proximally. So if we take this example of a patient with a leg length discrepancy, and we can clearly see the asymmetries that are occurring, if I stick a heel raise in and I look for the asymmetries, I can see that we've improved symmetry. I'm moving in the right direction. Similarly, I have a patient here that's got a lot of asymmetry proximally at the pelvis and hip. The E version of the shoe's not too bad, but they've got a higher degree of tibial rotation. So if I want to reduce that, well, I've had an effect on the right tibial rotation, but not on the left, right? So that's an asymmetrical response. And I'd suggest the reason for that is the driving force for that tibial rotation is the poor proximal control, and the orthoses isn't able to overcome that. But now we put the orthoses in the shoe deforms a bit more, and you get a little bit more movement. But if we look proximally, we've moved this patient more towards symmetry, but we can clearly see there's still dysfunction, and the orthoses aren't the only solution. This is a really busy slide coming up. All I want you to look at is the green ones are pre, and the purple ones are post orthoses. And I think you only have to glance there and see that there's not a lot of difference between the pre and post. Some things are a little bit better, and some things are a little bit worse. Why is that? Well, they've got an excessive step length. The orthoses are going to make no difference to that. Therefore, what we need to do is target the step length. So in conclusion, there's minimal evidence that orthoses or footwear will prevent running-related injuries. There are subject-specific responses to altered function. A comfort filter is as good a start point as anyone. If you're giving someone an orthosis and it's comfortable, they're running in a shoe that's comfortable, it's probably not doing them too much harm. You're nearer that preferred movement pathway. Don't change the shoes if there's no indication. And why would you use an insole if you haven't got a problem? I mean, I would like to think in podiatry now that we only use orthoses in patients that have got a particular problem. In terms of management, so what we'll now do is to determine the abnormal load and then target that, and perhaps modify in the short term. I think there's a role for orthoses in the short term with particular conditions. The further you get away from the foot, the harder it is to predict what you may be doing and how you're changing the loads on it. So for those complex problems, I think you need to have a more global assessment of the effect of interventions and a more specialist analysis. So I think there'll be a subset of patients that aren't responding to the management plan, or they're getting repetitive injuries, and you really have to then try and pick that apart. Thank you.
Fantastic. Well, great slides. I was like pressed up against the screen like this, looking at them. Fantastic information, Trevor. Thank you so much. Really good. Let's just let people in. No, thank you very much. I appreciate it's really difficult, particularly for you in half an hour, to kind of say, right, I'm going to tell you everything about shoes and orthosis now, but you did a great job, mate. That was really cool. I really am looking forward to, I mean, I'm so glad that you guys are getting the recording, because there's so much information on those which are applicable. Right, so fantastic. This is where we go to 15 minutes question times for Trevor. So you can either put your hand up real time, or you can activate the little blue hand in the box, or you can write something in the chats.
We have a question from Matt Scarborough.
Let's have a look there. Let's go. Good morning, Matt.
Good morning.
How are you?
I'm all right. How are you?
Very well.
Morning, Trevor. Thank you for that.
Yeah, cheers.
I haven't quite worked out if this is one question or three questions, so I'm going to try and roll it up into something that you might be able to answer.
It's 4 then.
Yeah. So there's minimal evidence that shoes are related to running-related injuries, if I understand correctly. But there was a slide where you discussed briefly a female runner who moved into the Vaporflies and ended up with symptoms as a result of going straight out and doing sort of 13 miles. And so if that was, assuming that that was a distance that she was comfortable with, and a distance and over terrain that she was comfortable with at a pace she was comfortable with, would that suggest that the shoe could be related to a running related injury, and that it provided a symptom for her? And in which case then, as therapists working with runners, what kind of advice should we be giving to runners in terms of, they've just gone out, they've bought a new shoe, they've bought it based on comfort? Should it become their primary shoe? Should it be something they include and chop and change between shoes as they kind of break it in, if you will? Or should we be sort of saying, actually, yes, it's a new shoe, but don't go out and do your normal distance in them? Do you see what I mean?
I think, I think that is 4 questions, but a great 4 questions. So firstly, let's talk evidence. So, and I have to be a little bit careful what I say, because I'm involved in a Cochrane review looking at this, but essentially when you take well-structured studies that have got control groups, etc., there's no consistent evidence that if you do this with this group of people, you get less injuries. Right? So the hard evidence is not there. That doesn't mean on an individual basis you can't get a problem. What I hope that slide showed with the 3 different shoes with the different pressure analysis is that when you change the shoe, you change the loading underneath the foot. Therefore, by definition, you would change the loading within the soft tissue structures, the joints, etc. And in her particular instance, when you go to a rocker sole shoe with a stiff carbon fiber plate, that completely changes the loading. And what was interesting for me was how in that particular shoe, you could really show that it meant that she loaded laterally for far longer and didn't transfer onto the medial aspect. So that completely changed her function. That doesn't mean that she wouldn't be okay in that shoe. It meant that she shouldn't have just gone and done 13 miles in it. And she came with a history, because she said, I did half a marathon. I decided to do a half marathon in them to see how fast I do them. And I got this problem. I stopped wearing it, it's gone away. So she gave me the diagnosis. It was easy. She wanted to know why. So we were able to tell her why. But she needed to adapt to that. And so that's where she will vary from the literature. So I can demonstrate why she got the problem. But that doesn't mean that that shoe will always be a problem if she adapts to it properly. Which takes us on to the next bit. So they go and get a comfortable shoe. And let's say they're in a comfortable shoe and they're used to running 5 miles. And then they go and run 10 miles. right? Well, they could still get an injury because it doesn't matter what shoe they got on, they've just doubled their load. You change the shoe, so they go, you know what, I used to love this shoe, I bought the next one and I've got an injury. Well, because the money shoe companies tweak things all the time, so it's not the same shoe, right? And therefore, inherently, what they should be doing is saying, okay, does that feel as comfortable as the shoe I ran in? No, it didn't. I wonder if there's another shoe that feels a bit more comfortable. Would be a more sensible approach, rather than just sticking with it, unless you can be certain. So I'll give you, and I know this is going to be video, but I'm pretty sure this is accurate. I don't know if you remember that ASICS used to do 2015, 2016, 2019, 2100, and now do a GT 2000, right? And the reason why they stopped changing the model was because people kept moaning that they changed the model. So by keeping it as a GT 2000, it's the same shoe, even if it changes, right? So, you know, that takes us on to the psychosocial side. I actually did prepare a slide, Matt, but as I had 58 slides in 30 minutes, I didn't think I could put any more in on the psychosocial aspect of orthoses, which Griff and Simon Spinner have been discussing. So I think, you know, you can't divorce the shoe from the training program. But if you're in something that's comfortable, but if you then you want to run faster, you may be better in a different shoe. But that's only experience is going to tell you that, unless you do some formal analysis. So we certainly do people at different speeds. So with the 3D, we have a database at different speeds. So we can say, okay, well, when you run at this speed, actually you look better in this shoe than you do at that speed. And I think I showed you that we're beginning to see that in the evidence for the stiffness of the shoe. It's a different stiffness at one speed compared to a different speed.
So as a therapist working with a runner, if we don't know the ins and outs of a particular build of a shoe, you know, if we don't know them quite as well as say yourself does, should we be advising a gradual transition? I think Sarah Jones asked a similar question yesterday. Do we advise a gradual transition to any shoe, or just in case they're one of these outliers for whom the shoe is having a significant impact on their soft tissues? Because comfort may only, I mean, the injury, I suppose, may only become apparent further down the line in the run.
Yeah, I mean, I think I've just got to say, yes, it's got to be a transition. I mean, I went back to the thing, I see patients, right? So I see people with problems. So I'm working out why they've got a problem, therefore what are the features I want from the shoe. But if you, I mean, I will regularly go, if you go online and try and find out the specifics of the 4% shoes, you can't get it. And different sites will tell you different thicknesses and different heel heights. So you just don't know, right? You know, so you've got to be getting that feedback from them. So it is tough, right? And that's why I'm sort of saying, you know, as a therapist, you sort of say, okay, well, why do I want to change the shoe, right? Why would I want to change the shoe? And if you think they need the shoe, but you're just not sure, I'd suggest that's the time you say, I'll tell you what, why don't you go and see so-and-so to get that advice, right? You know, because they might have a little bit more information on that than I've got. And I'm not saying all running shoe stores are naff, because some of them are very good, right? But if it's being based on you know, I've been on there, let's look at the angles, right? That's got to be the best shoe for you. And we know that that's not right.
Okay. I'm going to stop there.
I hope that's answered the question.
Matt, you've got this ability of predicting all the questions that everyone else is waiting to ask. It's a gift.
I'll button it now.
No, it's still a question that other people want. So, Sarah, I think that helped answer your question as well with the transitioning and stuff. We got a question from the Italian one, I believe. Go for it.
Hi, Trevor. Thank you very much for a fabulous presentation. Trevor, pressure analysis. How clinically valuable would be to inform, not predict, to inform our strength and conditioning for our clients? So I know the pressure, yeah, so I know that pressure and load is not, you know, might not be predictive of injury, but surely under the pressure analysis, for example, if I see increase pressure under the first MTP joint, I might want to direct my strength and conditioning for that joint or for the movement to be able to cope with the load. So do you think it's still relevant, or should we not consider it?
So I have a 1-hour presentation on pressure analysis in sport. I first got that insult system in 1995, and it transformed the way that I manage my patients. I think what you have to realise is, let's take your example of increased first MTPJ load. What the pressure analysis tells you is there's increased first MTPJ load. It doesn't tell you why.
Yeah.
So you still have to go and look why. So the best example I give people is, if I see an early heel lift, I could have an early heel lift because they've got a bony block at the ankle.
Yeah.
They've got tight calf muscles. They've got fixed knee flexion. They've got a hip problem. They've got a leg length discrepancy. They're running at a speed, whatever. So I've still got to find out why. Where it becomes really, really interesting is it shows you where there's obvious asymmetry. So I could show you a picture of my daughter's feet that are symmetrical, but she loads asymmetrically. And she loads asymmetrically because she has poor control at the hip on one side and stiff tibial function on the other side. And you can completely change it around with footwear, right? You see people where they load the foot and the hallux comes down very early in the step to stabilize the foot. And that's because they can't stabilize the foot, and it's a proximal problem. We can't do anything with orthoses with that. In the runner that I showed you that didn't get the heel contact,
yeah,
there is no way in a month of Sundays I could have treated her without that pressure analysis data, because I wouldn't have known her heel wasn't contacting the ground. So in terms of how it informs your practice, it's your camera inside the shoe.
Yeah, I can only do oh, I cannot hear you. My system allows me only to do unshod, because it's an I'm cube, the AM cube, so it's not really sensitive enough for, but it gives us a good idea of where
100%. It's better than nothing.
I mean, for what is related to me, because I don't need to be house specific, but it's good as I think it's good as a monitor, although I know that there is no evidence as predictive, but monitoring my intervention, you know, as long as it's done systematically, and I find it valuable, but evidence is not there, is it?
Yeah. Your only problem with a pressure plate is if you're running them over it. Did you run them over your pressure plate?
Yes, I do.
Yeah, the only problem there is you're running them barefoot.
Yes, it's unshod, yes.
So you may have altered heel contact because they're barefoot.
Yeah, you have to take that into consideration.
Yeah.
Yeah, for sure. Okay, thank you. Yeah, that's really valuable. Thank you. I'm gonna go now. Okay.
No, that's great. No, great questions. Shweta, I believe you have a question.
Hi, Trevor.
Hi.
So my question is, would you use orthosis as a tool for as an intervention during rehab, but not so much during running, in case you want to create a desirable kinematic or a kinetic, movement change or pattern change in the runner? Like you would use it in rehab, but not in running. Would you consider that?
When you say not in running, what do you mean by not in running?
Not having them use the orthosis in running, but use it more in rehab and in everyday life to.
Okay. No, if I'm treating someone with a running injury, and I think orthoses are part of that process, then I'll have them use them running. I don't have a problem with that. But whether or not they need them long-term for running is another matter. What's common actually is people often think they only need to use them when they're running. right? Well, if your response is a little bit unpredictable, actually what you need to do is to allow your body to respond and then do your running, right? So you should be using them as much of the time of day. And in particular, if we believe that we can offload a structure, we want to offload it for as long as possible. So they should be wearing it for both.
Brilliant. Thanks, Trevor. Is that okay?
Okay, yeah. Thank you.
Trevor, I've got something on my mind that I'd like you to answer. What about dosing? I've seen some great stuff from yourself, Spooner, Griffiths. Does that mean if you really are dosing, should you be modifying the orthotic device bit by bit, maybe even from week to week, or definitely kind of every couple of weeks, to change that tissue and allow the subject to maybe be loading a little bit more on what you're trying to originally offload? Or does that just get impractical because of the money?
That's such a great question. So to explain to people, if you had hypertension and you required medication for your blood pressure, they give you a certain amount, and then they gauge your response, and then they dose it accordingly. And a lot of the time it's done as milligrams per kilogram or whatever. What we don't know with orthoses at the moment is that when we put an orthosis with material X, shape Y, into a shoe, how much force we're actually applying to the foot. So we've got loads of work to do on dosing, because you can't do proper orthosis study until you can control the dose. In answer to your question, Matt, in reality, what a lot of people do is that they apply a degree of load to the foot, gauge the response, and then adapt. Now, if I go back to the Italian one, in our more complex patients, what we will do is we will put an orthosis in the shoe, we'll retest with the in-shoe pressure analysis, we'll see the response, and we play around with the orthotic until it gives us the loading pattern that we want. And then that will be the device that they go off with as their trial, and then we can work around that. And I have an absolutely terrific pressure picture of a patient who had lateral symptoms. And what we did with that particular person, we ended up giving them a custom orthotic that had the shell material was flexible in the arch and stiff along the lateral border. So we were changing the forces just by the density of the material, the thickness of the material, with a very small wedge. And she loaded just laterally all the way through the step, but with the orthotic transferred over onto the medial aspect of the foot. So we can, that window inside the shoe for the more complex patients, right, allows us to look at what effect we've done in terms of where the pressure, the force is going. But there's much, much more we need to do in terms of the dosing. I wanted to put in as well, as you brought it up, so Griff and Spooner came up to clinic just before lockdown, and we played around with Griff. You know, he likes his shoes, right? So we ran him in the 4% and the next percent, and the 4% is on his heels, the next percent is got more load on the ball of the foot. It's really interesting. So we're just kind of crunching through loads of data at the moment, looking at all. So yeah, so dosing is a massive thing.
Yeah, and on that subject, I think I asked this to Griff last year as well, or somebody else did. I think a nice takeaway thing from speaking to any podiatrist like yourself is how does because clinicians, sports therapists, physios are famous for referring out to podiatrists. It's an area which we either fear correctly, or I don't know, or maybe we're too fearful. But how do we know if either a therapist is working with a podiatrist, or if a runner goes to a podiatrist, that they are a forward-thinking, progressive podiatrist who has moved away from maybe traditional practices which need to be left? What are some key things that you would say highlight that a podiatrist is moving with the times?
Oh, well, if you send 10 patients to a podiatrist and all 10 patients get an orthotic, they're probably not with the times. If you send, do you know, I mean, if someone refers me a patient, so the patient just doesn't come and says, oh, Joe Brooks down the road said it. But so if you send me a patient, Matt, when I write my letter, you'll get a copy of my letter, right, which will detail all my thought processes in it. And I think it'll be the same as me. If I want to refer to a physiotherapist, whatever, how do I know they're forward thinking? Well, the reality is you build up a relationship, don't you? So you need to be aware of what a forward thinking podiatrist thinking, right? does this podiatrist seem to tick those boxes? Yes or no? And the only way you're going to find out is to refer and communicate, I think. You know, I don't believe there's a one standard that you could look at that says this person ticks all of these boxes. None of the professions really have that. And we go back to a spectrum, don't we? That you have people that practice biomechanics at one end of the spectrum and people that practice at the other end of the spectrum. And then you have to say, in that Q&A, the Q&A we had yesterday, I say Tom Goon's memory of people's names for papers. Unless he's got a list in front of him. He's on one end of the spectrum for that, and I'm on the other one. I'm telling you, I can't remember anybody's name.
I think I was talking about this earlier on, but I think there's a, I don't know if Tom does it or not, but as speakers, we know there's a certain knack where we kind of go, I think it was a paper written, and you can see the eyes kind of go, where they're looking at their computer next to their monitor at the moment. So I don't know whether Tom does that, but I know I do it. But you have that kind of like relative, oh, I think it was 2006 with Van Gent or 2000, and you're looking at the other page. But yeah, Tom's amazing
because he kept coming up with names on different subjects. He couldn't have had them all prepared.
I don't want to give away the tricks because we've got obviously non-therapists or people, non-speakers here. But one other thing, what about, because I know like Ian Griffiths famously thinks, I think, that overpronation should be banned from the dictionary, and no one, if anyone says the word, then they should be kind of like banished. But if a podiatrist is still in their notes back to you saying, oh yeah, this person overpronates, or is it the word itself which needs to stop being used, or is it more the implications? Because I mean, somebody, I think it's like Craig Payne, for example, doesn't seem to mind so much the word overpronation. It exists. You can see, especially using the foot posture index, you can actually say he's quite happy to say somebody overpronates, and there's probably a link between overpronation and injury, so it's not a word we need to get rid of. But then I see Ian Griffiths saying, no, we need to get rid of the word. It's silly. It's got ridiculous connotations. Let's call it something else. Where do you sit on that paradigm, kind of?
So as you get a bit older, you get a little bit less worried about terminology. You know, people get really het up about shin splints, for instance. Well, if someone says shin splints, I think, well, if you've got the diagnosis right, I know what you're talking about. I know what kind of area, and it's going to be a range of conditions, and I'll work out for myself what it is. You know, so people get really het up about it. I mean, again, if you go to a spectrum, if we accept everything as a spectrum, if at one end is the most pronated foot you could possibly have, and at the other end is the most supinated foot, so some people are going to be more pronated than others. So I think what you've had is what the terminology is. And I think the real issue about overpronation is, how do you define overpronation? So how do you measure it, right? So how do you measure it? And then, well, what's the relevance? Because it's not being directly linked to injury. And that's partly because, so I'm a firm believer in patterns of function, right? That we look for one pattern of function in the condition. So we look at 60 people and we try and find out one pattern of function. If there's 3 patterns of function that could be related to that injury, then you've just mastered everything. So if you want to look at Andy Franklin Miller's work on athletic groin pain, they found 3 patterns of common function that occur in patients that have athletic groin pain. So they identify the pattern and they treat that. And therefore, if we have 3 body planes, it makes sense that there could be 3 planes of 3 patterns of function. I'm just picking numbers. And therefore, if you just look at rear foot eversion, but it's how much the rear foot everts and what the leg does and what the rest of the body does above it. And the reason why you can't get a persistent result is because you can't get 30 people that function the same way. So I think I can predict, I think I can predict with pressure analysis the people that are asymmetrical and that's not in the foot, right? I find my role, I see my role today as being, patient comes to me, how much of their problem is foot related? How much can we do and how much is elsewhere and how much is pattern related? So I think pronation can be on one. This patient has a pronated foot type. I actually use the foot posture index. I put it in my notes and I score it, but I describe the foot as well. So I'm saying, right, this patient sits on it. I would expect that patient to be more predisposed to conditions that will be predisposed to increased pronation moments, right? But the further you get away from the foot, the harder that is to do. So now I say to people, well, why don't you score up all the factors in this person that could increase pronation moments? So that could be hip adduction, hip internal rotation, knee flexion, calf inflexibility, rear foot eversion, tibial rotation, a whole range of factors. If they're all doing that, well, you'd expect to there's more of a pronation force on it. I'm not sure entirely. I think you have to have some way of quantifying the degree of pronation, right? Because we have to communicate with one another, right? You have to try and get that information across. And I use several different sort of formats to build up that. And then when I write my notes going, this patient's pronating, oh, can I say pronating? Yeah, we got a pronation force. And I start talking about pronation forces, then half the people I write to won't understand it. You know, so
it's interesting. It's great. I'm always fascinated by terminology. I feel we're going to have to continue this definitely in the question time. I'm hoping that people here will come along. It's like last year, the whole question of shoes and orthoses was like dominated one of the question time sessions. So you able to come today to question time? I can't remember. Did you say?
Yeah, fine. Yeah, no problem.
You okay?
Yeah.
Right.
Yeah,
well,
I'm fine.
We will pick your brain more during the question time later on. It'd be great.
Can I add one last thing in, Matt?
Go on, yeah, of course.
We were supposed to be in Brighton, right? And I do have a susceptibility on conferences to stay up too late and drink too much, right? So I'm in a far better state doing this online presentation than I would have been in Brighton. So thank you for that.
That's okay. True, you haven't had Spooner knocking at your door at 3 in the morning or something. Talking of which, if you've got Spooner's, Simon Spooner's mobile number or something, I might meet him as well. It'd be nice if we can get him along as well, because obviously you guys have worked together and got some great stuff to do.
Yeah,
so I might see if I can drag him up. Yeah, he sent me some fantastic images. That sounded really dodgy. He sent me some great stuff. But anyway, right. We're running out of time for that. So thank you, Trevor, so much. And we'll put a pin in that for the moment and definitely get back to it in question time. So many other questions I'm sure people have got to ask. Right, folks.
You're listening to Runchatlive podcast, putting the evidence back into running injury and performance.